So welcome everyone. Thank you so much for joining us tonight. We're extremely excited to be joined by Dr. Robert Frenck. So when the biotechnology companies Pfizer and BioNTech announced the unprecedented success of their mRNA-based vaccine against SARS-CoV-2 in November 2020, the world was electrified with hope that an end to the COVID-19 pandemic may be in sight. Since the FDA granted emergency use authorization for the first COVID-19 vaccine in December 2020, nearly 73 million doses of vaccine have been administered to date. While many of you have already or will be receiving your COVID-19 vaccines in the coming months, the journey to developing, testing, and implementing the SARS-CoV-2 vaccine is a historic feat in response to the most pressing medical challenge of the century. The University of Cincinnati and Cincinnati Children's Hospital Medical Center have played an integral part in the quest for a COVID-19 vaccine as clinical trial sites for both Moderna and Pfizer SARS-CoV-2 vaccines. This week, we will be led in a discussion on COVID-19 vaccine development and implementation by Dr. Robert Frenck Jr. Dr. Robert Frenck Jr. is the director of the Gamble Center for Clinical Research and Vaccine Research Center at Cincinnati Children's Hospital Medical Center and a professor in the Department of Pediatrics at the University of Cincinnati. After receiving his MD from the University of Texas Medical School at Houston, Dr. Frenck completed his internship and residency at the U.S. Naval Hospital in Bethesda, Maryland, as well as a fellowship in pediatric infectious diseases at the University of Texas Medical School at Houston. Dr. Frenck is an international authority on the assessment of vaccines and agents against novel infectious diseases. As the principal investigator for the Pfizer COVID-19 vaccine trial at Cincinnati Children's Hospital Medical Center, Dr. Frenck oversaw the Cincinnati clinical site of the phase 3 trial that led to the emergency use authorization for the first COVID-19 vaccine in the United States. Additionally, Dr. Frenck is a national leader in the evaluation of the efficacy and safety of vaccinating adolescents against SARS-CoV-2, as Cincinnati Children's is one of only 5 sites in the world testing adolescents between the ages of 12 and 15 years old. Dr. Frenck's contributions to the evaluation and implementation of the Pfizer COVID-19 vaccine have been published in prestigious journals, including Nature and the New England Journal of Medicine, and his expertise has been widely featured in the New York Times, Washington Post, ABC News, and National Geographic. Dr. Frenck, thank you so much for leading this discussion on COVID-19 vaccines, and I'll let you take it away.
Thank you, Scotty. Thank you for having me. And so today, what I just wanted to do a little bit is to go over about the development of the vaccines and then talk about the different platforms. And so that what I'll look at doing is instead of going over everything with every vaccine, because a lot of the things for good, it came out very similar results, is to talk a little bit about animal model and then go into human for each of the vaccines. So just in the interest of time, won't repeat everything for every vaccine, but the good news is that the results basically came out very similar for all the vaccines, which is really good news. So before starting, I thought really go over a few myths or untruths, whatever you want to call it, and that the first thing is that the vaccines, COVID-19 vaccines, do not make you infertile. That there's been a lot of talk about that it decreases fertility. It's just not true. The COVID vaccines do not modify your DNA. That the mRNA vaccines actually don't even get into the nucleus. And for the adenoviral vectored vaccines, while the adenovirus DNA is in the nucleus, it quickly then is translated to the mRNA and it goes into the cytoplasm. So it does not incorporate into our DNA. It doesn't give you positive tests on PCR tests. That's one of the things people worry as far as they get the vaccine, that they're going to turn positive for the PCR. But the PCR is measuring antigen where the vaccine creates antibodies. It won't give you COVID. Is that while there are live attenuated vaccines that are being tested in parts of the world, in the United States and many other countries, we focused on the mRNA vaccines and the adenoviral vector vaccines and the protein subunit vaccines. And unfortunately, they don't protect you against the flu or vice versa. Now, the one thing I would say is that so far, we've had almost a historically low flu season. So maybe if anything of a positive out of COVID, that may be the one positive thing is that our other respiratory viruses have been way down. RSV has been way down and flu. The other thing too is that even if you've had COVID-19, you do need to get a vaccine. A lot of people said, oh, I've had the virus, I don't need to get the vaccines. That's not true. We're still recommending people to get the vaccine even if you've had the virus, and that's because people still have shown a good boost in immunity after receiving the vaccine. So this slide is just a little bit of basics as far as how we develop immunity, and so give you an idea about the virus. And so here's kind of a cartoon representation of the coronavirus, and this here is your spike protein, and the spike protein is the target for all of the COVID-19 vaccines. And then there's the M protein, and then also the N as in Nancy protein, the nuclear protein. And then there's an E protein too as an envelope. And so that the vaccine is against the spike. And so that one of the things that I just say to remind people, as far as we've had a number of people that have come in and wanted, after vaccination, they wanted to go get antibodies tested to see if they've really got the vaccine. So they're trying to kind of unblind themselves. And we've had some people come back and say, well, I must have gotten placebo because my antibodies were negative. But a lot of the antibodies are measuring against the nuclear protein, and they're not measuring the spike protein. So if somebody goes and gets an antibody test, you have to make sure they're getting the right test, because we've had a number of people that have been confused and angry of saying that you didn't really give me vaccine because I don't have any antibodies. But like I said, you have to make sure you're measuring the spike protein. So anyway, for the virus, what happens is the virus then, they have the receptor in the ACE2, and that's where initially people are finding that, that people that are on ACE2 inhibitors actually may have an advantage against the virus, but it doesn't really seem to have panned out as much. But this is where it binds, and then it comes into the cell. And then, as we know, as a virus, that a virus is not a free living organism. It hijacks the machinery of the cell. It lets go of its RNA, and then it translates the RNA into proteins, and it makes a new virus. It buds off, and then it finds other cells to go infect. And then so for our immune response is that we're doing is that here's again, the spike protein is that our antigen presenting cells are engulfing the spike protein, putting it on the surface, and then a T helper cell, which has a specific recognition site for the spike protein, binds. Then it stimulates B cell production, and it also stimulates killer T cell production. And so that this is the way that our body works to try to fight off an infection. And basically the vaccine is doing the same thing as far as stimulating the same immune response, but it's doing it without us having to get sick, without getting the infection. And so here's just a electron micrograph of a coronavirus. And so the corona means the crown or circle of light. And this here is the spike protein, which you're seeing here. And so this is the area that we're making our antibodies against that spike protein. I'm just going to move this real quick. And so that just as an update here, as far as giving an idea of the number of vaccines that are in development, this was a couple months ago, that there were 37 vaccines that were in phase 1, 27 in phase 2, 20 in phase 3. So this authorized is throughout the world, 6 and then approved. And so phase 1 is just the very early testing, where we're testing maybe 100 people or so to see about immunogenicity and safety. Then phase 2 moving into more immunogenicity testing and further safety testing. And then phase 3 is when you're actually looking at the efficacy of the vaccine. So this slide, is looking at, people talk about, well, things have gone too fast. How did it go so fast? Why shouldn't I be worried about the vaccine? And that really what I would say is that it's the science that's been available that allowed us to do things as quickly as we have. So that the platforms we're using with the mRNA and for the adenoviral vector platforms, as well as the protein, have all been in existence, and so that they've been tested for a number of years. They just haven't been used in a licensed vaccine. So it's not where you started from ground zero. The other thing that's really important is that the companies had a lot more confidence to be able to put resources and go forward because our government supported the trials. And that's why the vaccines will be free of charge to us. There still may be an administration charge, but the vaccine itself won't cost because we've already paid for it. But that's really what allowed us to do things much more quickly, is that so it was in actually January of 2019, January 2020 is when we identified the virus, and then we're able to sequence the genome, and then immediately started preclinical or animal studies. And that we then, within 3 months, using these technologies, like I said, that we had, we're able to begin clinical trials. And one of the nice things about the mRNA and the adenoviral vector vaccines is they can very quickly be ramped up, so that in a matter of weeks that you can make a vaccine. And this may be important in the future, is if we find the variants that you will need to tweak the vaccine, that these technologies allow that to be done very quickly. And then so we started the phase 1-2 trials right around here, and then the phase 2-3 started in July, August, and they completed in about October or November, and that's when the emergency use was right in here, November to December timeframe. So that it's not that any corners were cut. What it was is really things were more telescoped down. So that typically in a clinical trial, we would collect data and send it off maybe every couple of weeks. We would, same thing with serum samples, send it off every 2-3 weeks. Here we're sending off the data. We have to have it entered in the computer within 24 hours, and the serum samples we're sending 3 times a week, so that things are been done much more compressed that way. And then there's just a lot of hours put against it. The other thing too is that the FDA was in contact with the manufacturers the whole time, so they were getting information as it became available, which allowed the FDA to do a more timely kind of review at the end when the phase 3s were finished, versus having just given all the information at once and having to go through it. So it was a compendium of events that would allowed things to really go faster. So what I'm going to do, these are the talk about some of the different approaches. So these are the 5 main approaches, but just in the interest of time, I'm going to talk about the viral vector, the RNA, and the protein subunit. So an inactivated or live virus is being evaluated in parts of the world, mostly in China. And what they're doing is you take the SARS coronavirus 2 and you passage it in tissue a number of times. What happens is it loses its pathogenicity. It still has the spike protein on the surface and that, but it just doesn't make you sick. So you're as close as possible of giving a wild type infection without making yourself sick. And then the DNA vaccines are ones that people have been working with, but really have not progressed to this stage of phase 3. And so, like I said, interest time to leave those alone. And so then for the candidate vaccines, the main ones we're talking about here is the nucleic acid and the viral vector vaccines. In the end, what's happening is with all of them, you're getting the mRNA from the spike protein that's taken up into our cell, and then our cells make the spike protein and then start the immune response, like I showed you in the slide a couple slides ago. So first, as far as talking about the mRNA vaccines, and the 2 that have had emergency use authorization in the United States of the Moderna and the BioNTech Pfizer vaccine. So here's looking at just another cartoon as far as with the mRNA. So what you're doing is you're taking the spike protein of the spike protein gene, and then you're putting it in a lipid nanoparticle. Initially, they tried just to have naked mRNA, and that got chewed up before it ever made it into the cell. So you had to put a lipid nanoparticle around it. Then that gets engulfed, and then in the cytoplasm, our RNA, that mRNA is translated using our ribosomes into spike protein. And then the spike protein is put up onto the surface of the cell, which then stimulates the MH1 and MH2 antibody responses, as well as stimulating the T cell and B cell, so that it's a very broad type of immune response. So this slide then is looking at non-human, so macaque primate data for the Pfizer vaccine. And here what you're looking at is neutralizing titer. And so what a neutralizing antibody is that is an antibody that prevents the virus from entering the cell. And so it neutralizes the virus. And so this is then looked at as a functional antibody. And that so this is the titer of the neutralizing antibodies versus the days after the first vaccination. And so this is the 30 microgram dose, and this is the 100 microgram dose. The 30 microgram dose is what we ended up using in the phase 2-3 human trials, because the 100 microgram, while it produced a good immune response, was too reactogenic. And then this is human convalescent sera. So looking at the titer that was produced and finding that at 7 days after the second dose, so 28 days after the first dose, you got a good rise. And this is what you see here is this is when you gave the second dose, is that this big jump. This is why we think that the 2 doses of the vaccine are important, because you get a very big rise in the B cell, in the immunoglobulin response with that second dose of vaccine. And that as you increase the dose, your vaccine response is higher, your immunity is higher. But like I said, the trade-off was the reactogenicity was just too hot. And so we discarded this dose. But the other thing you can look at here is the neutralizing titer of the human convalescent sera. So these are people that have recovered from COVID, and the titer, the neutralizing titers they had versus getting the vaccine. So you can see that the vaccine at least was equivalent to human convalescent sera and likely higher. So this data is then looking at the ability to find the virus in the lungs versus being able to find it in the nose. And so the lungs we're looking at, so here's the viral load, and then this is the sentinels versus controls, and this is vaccine. And so what you see is in the controls that you find virus in the lungs even 6 days later, whereas in the controls, in the sentinels, which got nothing, and also in the vaccine, you don't ever see virus in the lungs. So what that's showing is that the vaccine is totally preventing the animals from having pneumonia. The other thing here is that looking at then the nasal swab is trying to look at about infection, and that again here, this is the placebo, if you will, that got nothing, the control that was infected with a virus but didn't have any vaccine, and then these are the ones that received vaccine. Is that for a day that you found that there was virus in the nose of the immunized animals, but it was gone by day 3, whereas with the control animals that were infected, that at day 3 still had virus, and even at day 6. So that this is small numbers, but it's at least suggestive that the vaccine may prevent infection as well as disease, the pneumonia. And that's one of the things later on, as far as talk about, is that the definitions is that while we would love to have a vaccine that prevents 100% of infections and also has no side effects, is that what we end up doing is basically finding the place where we're getting the best protection with the lowest side effect profile, or the best side effect profile. And that and so we may not be able to totally prevent infection, but if we can prevent severe disease, that's the thing that we're really trying to do. And so then moving here to a human study is again looking at the neutralizing titers versus time. And so this is on the placebo, and then they got their day 1, oops, this keeps moving on me. And then this is the lower dose. This is 10 micrograms, 30 micrograms, 100 microgram dose. And again, the human convalescent sera. And then here they got dose at day 1 and dose at day 21. You'll see for the 100 microgram, like I said, we abandoned the 100 microgram dose after that first dose because people were having too many adverse events. But what you can see again is that with that second dose of vaccine, you have a huge jump in both the 10 microgram and the 30 microgram the neutralizing titers. And so again, this is why we think we need that second dose, because you get such a boost with that second dose. So this is looking at then is the CD4 and the CD8 response in humans that are vaccinated with the Pfizer vaccine. And what we're seeing is that that when there's the control, that they really had no response, the T cells, either the CD4 or CD8, is that you got with the vaccine that you had a pretty balanced response between the CD4 and CD8, which is important because we're wanting to have as much as we can as a Th1 response, because that Th2 response looks like that was what's been associated with enhanced disease, and that's not what we're seeing here. We're seeing a really balanced CD4, CD8 response. So then moving as far as to the local side effects with the vaccine, is that this is the percentage of side effects here, and then this is the vaccine placebo. So this is the 16 to 55-year-old group, dose 1, dose 2. This is over 55, dose 1, dose 2. So one of the things that we've seen with all the vaccines is that the adverse event profile is there's more adverse events in the younger group and the older group. Not sure exactly why, but we've seen that with all the vaccines. And that the other thing, so this is just the local, so I'll show you more in the next one with the systemic, is that for the mRNA vaccines, so for the Pfizer and Moderna, we had more adverse events with the second dose, whereas with the Johnson & Johnson and the AstraZeneca, there's been more adverse events with the first dose. I can't tell you why the difference is. I can just tell you that's what we've seen. And so this is then looking at the systemic side effects. So fatigue, fever, fatigue, headache, chills, vomiting, diarrhea, muscle pain, joint pain, and the need for use some sort of antipyretic. And again, the percentages. And here again is the first dose and the second dose for the younger group versus the older group. And what you can see is, I was mentioning, as far as that, if you compare here to here, you see that the frequency of adverse events went up for fatigue between the first and second dose. If you compare here to here, you'll see that the frequency of adverse events was higher in the younger group as compared to the older group. And so then, as far as what efficacy results we found, is that when this was published at the end of December, there were 43,661 participants enrolled nationally. And beginning 7 days after the second dose, the vaccine was 95% protective against COVID-19 disease. And what that translates to, that there were 170 cases of COVID, 162 in the placebo group, and that of the 10 severe cases, 9 out of the 10 were in the placebo group. So it prevented not only disease, but severe disease. And the thing that was really tremendous, and we were worried about what would happen, as far as that the efficacy was consistent across age, gender, race, and ethnicity. And if you looked at people over 65 years of age, the efficacy was greater than 94%. So that really the vaccine performed wonderfully throughout the age range and across all other demographics. So one dosage of vaccine was sufficient for all adults, and that was what we were a little concerned about. Would we need to have different vaccine dosages depending on groups? And we did not. So this is then looking at a pictorial representation of the efficacy. So here, this is the cumulative incidence of COVID cases over time. And so they got the first dose here, they got the second dose here. And so this curve here is the placebos, this curve here is the vaccine recipients, and the difference between the curves is the number of cases of COVID prevented. And so you can see is that the vaccine curve is basically flat, whereas the placebo curve is about a 45-degree angle. This insert here is then looking at the first 21 days. And so what you can look at is about day 12, you're starting to get some separation between the vaccine, the placebo and vaccine group. But this is not the way the study was designed. It was designed as a 2-dose study, so it's hard to really get too much information out of this. But if you look at this period from here until here, which is day 28, the efficacy was about 52%. And it's that, so after day 28 here, is that anything this way, really you're taking into account that second dose of vaccine. So it may be that if we gave 1 dose of the Pfizer vaccine and just watch, that you would have a 90% efficacy or 95% efficacy with that too. We won't ever know because of the confounder with that second dose. But at least what you could say, as far as the 1 dose, it does give you protection. It's just not, it looks like you get that really great protection with that 1 week after the second dose. So then moving over to Moderna, and this is that Dr. Fichtenbaum at UC was the head of the trial there. And that so here again, we're back to non-human primate data and looking at T cell responses. And that so again, looking at the Th1 versus the Th2 response, you can see the Th2 response is basically 0 in the animals, whereas the Th1, this is saline, and you're getting a 10 microgram dose and a 100 microgram dose, is that you got a significant increase in T cell response in between saline and a 10 microgram, and then you got another increase when you went from the 10 to the 100 microgram dose. And that, like I said, it was all a Th1 response. Here's just the same kind of thing as I was showing you before as with the Pfizer. This is with the Moderna vaccine, is looking at the virus in the BAL, so in the lungs, the bronchoalveolar lavage, versus in the nose. And this is then being able to identify the virus in the days after challenge. And so what you can see here is that no virus was found in the monkey's lungs, which is great. So again, prevented disease. And that if you look at here, the 10 microgram, you found the virus for 4 days still in the nose. So it didn't prevent very much against infection. But if you go up to the 100 microgram dose, only on day 1 did they find virus in the nose of the monkeys. So this could actually even be because you've instilled the virus. You just find it still there because it was instilled that day. So what I would look at this suggesting is that the Moderna vaccine was tremendous against the preventing disease again, and that at the higher dose, the 100 microgram is what was used in the phase 2-3 study in humans. That looks like it may also prevent infection, or at least decrease it compared to controls. And so here again, we're looking at neutralization titers and the humans. And the thing that's, this keeps moving on me. The important thing that I forgot to mention is that so the this is regular antibody here, so the just IgG, and this is the neutralizing. Is what there's a correlation, pretty direct correlation between the elevation in receptor binding domain, the IgG, and the neutralizing titer, which is nice because the neutralizing assay is a lot more difficult than just measuring IgG. And so for all of the vaccines, so for the Moderna, for the Pfizer, for the AstraZeneca, for Janssen, for Novavax, that there's a very good correlation between the neutralizing titer and the receptor binding domain, the regular IgG, if you will, which allows us just to measure the IgG, and it's a lot easier technology. So then, similar to what I showed you with Pfizer, here's a local side effects with Moderna. Again, the percentage of people that having side effects, and this is then placebos, and this is dose 1 versus dose 2 of the Moderna vaccine. And so it's any adverse event, pain, erythema, swelling, or lymphadenopathy. So you can see the local side effects overwhelmingly was pain. And this is looking at the systemic adverse events, similar type of layout. So these two here are placebo. These last two here are vaccine. So one of the things that's important, I think, to look at here is that one of the reasons why we have placebos, if you look at headaches, the percentage of people that had headaches after each dose of placebo was almost the same as after the first dose of vaccine, and the same thing with fatigue. And so what is very common is that people are in a clinical trial, and so they're paying attention to things they may not pay attention to otherwise, and say, yeah, I did kind of have a headache, or maybe I did feel a little fatigued, or my muscles hurt a little bit. So that's why you need the placebo group to really discern how much of these subjective adverse events are due to the vaccine versus just being in a clinical trial. So looking at the Moderna phase 3 results, that they had 30,000 people enrolled. They found the vaccine was well tolerated. The majority of adverse events were mild or moderate. And again, they had a tremendous vaccine efficacy of 94%. They had 204 cases of COVID with 192 in the placebo, and they had 30 cases of severe disease, all of which were in the placebo. So this slide here is very similar to the one that I was showing you before with Pfizer. Again, the incidence of the COVID, and that here this is the placebo group and this is the vaccine group, And again, between here, this is the number of cases that were prevented. And so that what they're finding is that they thought that after one dose is that the vaccine efficacy again was around 50%. So then moving on to the viral vectored vaccines, and the two we'll talk about is the Oxford AstraZeneca and the Johnson & Johnson. So here is that cartoon just looking at the development of a viral vector form. So what you're doing is you're taking the adenovirus here and you're putting the gene of interest inside the adenovirus, and that then is what's getting injected into us. And so the adenoviral vector vaccines were actually developed for pandemic response. That the AstraZeneca vaccine and Johnson & Johnson both were tested in Western Africa with Ebola and had been effective in Ebola prevention, so that we did have a good idea that this vaccine should work. So what happens then is that now we're bringing the spike protein gene into the cell with the adenovirus, and then the adenovirus lets go of the spike protein, and then again you have the mRNA and you're making the protein, which then gets put onto the cell. And just like with the Moderna and Pfizer, you're stimulating the antigen presenting cells to have the T cells, the B cells, and so again you have a very broad kind of immune response. So this is looking at the outcomes of macaques, monkeys that after vaccination with the AstraZeneca vaccine. So the red here is the monkeys that received vaccine. The blue is the ones that received placebo, and the higher the score is the worse that you are. So that you can see is that the placebo group had a worse clinical score, so they were sicker than the animals that received vaccine. And then here again, we're looking at the bronchoalveolar lavage, so being able to find the virus in the lungs of the monkeys. And so this is the controls and this is the vaccine, and that you just don't see the virus in the lungs at all. So again, showing you that the vaccine prevented pneumonia, whereas with the control monkeys, they had virus isolated for 5 to 7 days. So this slide is looking at the IgG by age and dosage. And so this is the concentration of the IgG over time. And so here, in the way that this study was designed, is it initially was a phase 1 study. And so here, what they did is at this point here, is they gave literally 10 people a second dose of vaccine. And then they saw what happened. And they saw that with the second dose of vaccine, people's antibodies rose as compared to the one dose, what happened over time. And so because of this elevation in antibody response, they changed the study at the last minute. It was going to be a 1-dose vaccine in the United States, but then they decided to have a 2-dose vaccine studied in the United States. And so here again, we're looking at the immune response, and that now what we're looking at is looking at Th1 versus Th2, and that and we're seeing here, this is the placebo group, so that they received a meningococcal vaccine. And so this is a group that just received 1 dose of the adenoviral vector vaccine, and this received 2 doses. And what you can see here is for the T cell response, 1 dose really seems to be sufficient. You get after 14 days after the first dose, you have a very nice response. And if you compare it to here, it's basically the same, so that the second dose did not boost the T cell response. So while the B cells had a big boost after the second dose for the Pfizer, Moderna, and actually AstraZeneca, we don't see that with T cells. Looks like the T cells 1 dose is sufficient. So here we're looking at the systemic adverse events with the AstraZeneca vaccine of the first dose versus second dose. And as I was mentioning before, you're seeing that the frequency of adverse events was more common in the first dose than the second dose. It was flip-flopped from the Pfizer and Moderna. And then this is then the same data set, but then splitting it out by age. And so this is 18 to 55, 55 to 69, and 70. And that, again, you can see if you compare fatigue, it's an easy one to see, is that there was more fatigue, excuse me, in the younger age group than as we're getting older. Same thing with joint pain is more in the younger group. I tell people, or muscle ache, I tell people when I get out of bed in the morning, something hurts all the time. So I just thought that was normal. So I probably wasn't even thinking about it being part of a vaccine. So then if you look then at the AstraZeneca phase 3 preliminary results, they had almost 24,000 participants with 11,635 of them available for analysis. And 5,800 had received 2 doses of the vaccine. So of those, 1,367 received what they called a low dose and a standard dose, and 4,400 received 2 standard doses. Well, what happened with that, it wasn't planned that way, is that in the factory there was a miscalculation of the titer of the vaccine, and so the low dose was thought to be a standard dose, but it was actually a mistitered, so it was a lower dose. And so people then were saying, well, look, if you give a low dose and a standard dose, you get a 90% efficacy, but if you give 2 standard doses, you only get a 62% efficacy. And there's a couple things. Is that one is that these are small, the numbers are relatively small, so that the confidence intervals of these almost overlap between the 90 and 62. The other thing that I think, though, is more important is that the timing between the first and second dose in the low dose standard dose was significantly longer than in the 2 standard dose regimens. So another way that you could look at this is saying that we need to give more time between the doses, and that will increase the efficacy of the vaccine. So I've had people ask me, you know, I'm supposed to get my second dose tomorrow, but I can't because I have something to do. Can I wait a week? And I said it actually may be better to wait a week. This is then looking at similar kind of data I was showing you for the other 2 vaccines of the AstraZeneca. Again, the cumulative amount of cases and the days since the second dose. This is the placebo, this is the vaccine, and the shading around it is the 95% confidence intervals. So that you can see there still is a fairly good separation between the placebo and the vaccine. It's a little harder to see because they added in the confidence intervals, which the other 2 vaccines didn't do. And so then here, moving on to the Johnson & Johnson or Janssen vaccine, this is again looking at the virus being found in the lungs. And so these are the sham animals that are at control. You can see there's a lot of virus in the lungs for a number of days, whereas in the vaccines, nothing. And this is looking at the nose, so that in the nose they had 1 animal that they found virus in the nose, but otherwise nothing, compared to all the animals in the placebo group that had virus in their nose for a number of days. One of the things you can see here as far as it having up to even 10 days, this is the reason why we have in quarantine for the 10 days, because that you can potentially shed for up to that long of the virus. So then here we're looking at the IgG response in the group, the 18 to 55 years of age, the titers versus the time. So here's your placebo. Here got low dose and then placebo, then got 2 low doses, then a high dose placebo, and then 2 high doses. And that what you can see is that the second dose may add a little bit of immune response, but not a tremendous amount for the Janssen vaccine. And this, regardless if you go from the high dose placebo or the high dose, you get a little bit of an increase in response, but not a tremendous amount. But you still do get an increase. And then here again, this is human convalescent serum. So if you compare this to after the second dose of the high dose of 2 doses of the 2 doses of the low dose, that these exceed this titer for the human convalescent serum. And this is the neutralizing antibody. So it's what I was mentioning to you before. There's a very good correlation between the IgG response and the neutralizing antibody response. So with the Janssen, as we can with other vaccines, we can just measure the IgG, which is much easier to do. Again, as I was mentioning with the other vaccines here, looking at a Th1 versus a Th2 response, is that you're getting almost all Th1 response, and that for both the low dose and the high dose. And if you see it's the same as if you're getting it the 18 to 55 or greater than 65, that you're getting a very nice Th1 response. So here's the local adverse events by age. This is the younger group and the older group, and that you're seeing as far as, again, that the younger group had more adverse events than the older group. And then if you're looking at systemic AEs, systemic AEs, a similar kind of thing, is that you're getting, excuse me, more in the younger group than the older group. So the interim analysis for the Janssen phase 3, they had 44,000 participants. That the one thing that's nice about this vaccine, it's only needing one dose. It's able to sit in a refrigerator, and the efficacy was measured starting 28 days after the dose. Now, what they found was a 66% efficacy for moderate or severe disease, but in the United States that was 72%. And if you look then at the definitions, so what they're saying for severe or critical disease, which is hospitalization or ICU or death, it had an 85% protection. So this is what I was mentioning as far as that, and the 85 and the 94, those confidence intervals likely overlap. So I would take a way of saying that all of the vaccines have a good protective effect against what we're really trying to do, which is to prevent hospitalization and death. And so that if you're offered vaccine, I wouldn't worry to say, oh, I'm going to wait until I get this vaccine or that vaccine. All of them have very good efficacy against the things that we're most interested in doing, which is to prevent severe disease. And then lastly is the Novavax, which is a protein subunit vaccine, and that they, like the Moderna and Pfizer, had more adverse events with the second vaccine than the first vaccine. But otherwise, the adverse event profile is about the same. And what you're seeing here is that as you're increasing the dose, you're increasing this side effect profile. And then when you're adding the adjuvant to it, you have a little bit more side effects, but you really need that the adjuvant to get your best immune response. And that's what this is showing, is that here is the antibody response, and this is placebo. This is a group that got 2 doses of the 25 micrograms of vaccine. This is a group that got 2 doses of the 5 micrograms plus the adjuvant. This is 25 micrograms plus the adjuvant. And this is where they got 25 micrograms, but in the first dose they got adjuvant. In the second dose, there's no adjuvant. And what you can see is that adjuvant had a significant increase in antibody response compared to no adjuvant. And so that's why the vaccine is being looked at of using an adjuvant. If you can see here, between the 5 and the 25 micrograms, there's really no difference in the the mean response. If anything, you might argue that the 5 micrograms is a little bit higher. I think that's probably an aberration. If you look at the confidence intervals, that they're probably the same number. So where are we with the COVID-19 vaccines? Is that we have now 3 vaccines that have been approved for EUA, the Pfizer, the Moderna, and the Janssen. The AstraZeneca has finished phase 3, and they're now just they're collecting cases, and when they get sufficient cases, then they will look at the efficacy and apply for the EUA. And Novavax also, they have completed their phase 3. The Sanofi, they are pending their phase 3. They started a phase 2, or they did a phase 2, and they did not get good immunogenicity in the older adults, and so they are reformulating the vaccine, and we'll see what happens with that. And so this is a slide I just wanted to talk to people as far as to show why it's really important that all ages get vaccine. And so this is the incidence of cases per 100,000 people versus time. And so this curve here is the greater than 80 years of age. So in the early part of the pandemic, the 80-year-olds had the highest incidence of disease. But now you can see this is 18 to 24-year-olds, and this is 25 to 44-year-olds. So these aren't that much lower, but you can say the highest incidence right now is 18 to 44. And then the other here is that this is the 0 to 13. So it's a bit lower than the other age groups, but it's coming up like this. And so right now, basically all age groups are showing about the similar rate of infection. and why we really need to immunize everybody to get to herd immunity. People were asking me, do I really think it's important to immunize children? And I would say yes, because we have 75 million people in the United States under 18 years of age. If you don't immunize those kids, you're not going to get to herd immunity. And then this is a positive slide, I would say, is looking at the number of doses per day that's given over time. And we're now, this is a couple of weeks ago, up to 1.6 million doses per day. And so that's still going to take a while to immunize 400 million people, but it's ramping up in the right direction, and hopefully soon we'll be above the curve here and rapidly be able to vaccinate. Is that currently, I will admit that the demand exceeds the supply, but I think that's going to be a rather short-term problem. I think within the next couple months that there'll be adequate supply for anyone who wants vaccine. So where are we at with COVID-19 vaccine trials at Cincinnati Children's Hospital? So we were one of the phase 1 trial sites. We were one of 4 in the world, but we then did the phase 2-3 trial in adults. And then we were one of 5 sites in the world for the phase 2 in adolescents. And we also enrolled for the AstraZeneca for the phase 3, and total we've now enrolled over about, well, that slide's a couple of weeks old. We're now almost closer to 1,500 people who've enrolled in the combined studies. So where do I think things are going? Next, I think we're going to be looking at studies in children. That we have done the trials in adolescents down to 12, but 3 companies now are interested in testing at younger ages, with the youngest age down to about 6 months. So what I see what'll happen is that we'll do age de-escalations. Probably start with 5 to up to your 12th birthday, and then look at the safety profile there, and then go down to say like 2 to the 5th birthday, and then 6 months to your 2nd birthday, and then see if we need to adjust the doses. And then what we find from that phase 1 part for the children is that then we will have a vaccine dose to be testing a bigger number of children. And then one of the things too I think is important as far as that for the adults, we did a true efficacy study. So we looked at the number of cases prevented. That would be really difficult to do with the kids, and it's probably not necessary. The reason it'd be difficult is because of the infection rate, is now dropping in a lot of places in the country because of vaccine and people being good about their precautions. Again, is that you probably would have to enroll somewhere more like about 60 to 70,000 people instead of the 30 to 40 that in before. The other thing though is that what we'll look at instead is what's called immunological bridging. As we'll say, we'll look at the immune response in the kids and compared to the immune response in the adults. And if the immune response, if the IgG is the same in the 2 populations, then the extrapolation will be is that the efficacy in the adults is going to be the same as the efficacy in the kids. We're also going to be moving into pregnant women and then looking at stability studies. So what we mean by the stability studies, excuse me, is to see if we can test the vaccine excuse me, too many talks. If we can test the vaccine at different storage temperatures. And then the 2nd generation vaccine is to be looking at variants. The good news is that right now, the vaccines have performed well against the variants, so we probably are going to be fine. But we are going to be testing some 2nd generation vaccines just in case. And I think that's it. I apologize. My voice every now and then gives out on me on the things, so that it's not my COVID, but that so hopefully that helps. And if there are questions, I'm happy to take questions on anything I didn't go over. And so thank you very much.
Absolutely. Thank you so much, Dr. Frenck. That was a truly fantastic presentation. I think there's so much information with vaccines, and to have someone of your caliber who's been so involved with, really the pioneering vaccines, to hear from you has been fantastic. So we have a question from Hannah. She says, thank you so much for the informative presentation. since younger age groups are having more adverse events from the vaccines, would adolescents have even more severe reactions? How could the vaccines be adjusted to be safe for the youngest of the population?
So that's a great question, Hannah. So that actually in the adolescents, we use the same the doses we did in adults, and that the the adverse event profile really has looked the same in the adolescents that it has in adults. It may be that we will be able to use the same adult dose in the children, but that's what we're going to do as far as with the children is first. So I can tell you for the Pfizer, because I'm just familiar a little bit more off the top of my head with the doses. The 30 microgram dose is what was used for the adults and adolescents. So that initially what we're going to do is to start with a 10 microgram dose in the 5 to 12-year-olds, and then see how the response is with that, and then either up the dose or down the dose depending on what the response is. So if the 10 microgram dose is too reactogenic, then go down to 3 microgram. If they do okay, go up to 20 microgram. What I can tell, if you go back and look at the phase 1 data from the Pfizer trial, in the 18 to 55-year-old, even the 10 microgram was quite immunogenic. And the reason that we went to 30 micrograms is because 10 micrograms wasn't immunogenic enough, we didn't think, in the population over 65. And so we just went with the one dose at 30 micrograms. But it may well be that we can decrease the dose for kids. And if you look at it like for a flu vaccine, the dose of flu vaccine we use in a 6-month-old is the same dose we use in a 64-year-old. And it's actually when you get to be 65 and above, you have to increase the dose of the flu vaccine. So it may be that, like I say, even an 18-year-old that we could do 10 micrograms and do and have just as good of an immune response as the 30 and the over 65. But so what we'll do is we'll continue to, as we age de-escalate, we'll be checking the safety profile with the doses and find where's the best combination of safety and immunogenicity.
Great. I just had a question, Dr. Frenck. So there's a lot of news out there about new strains from South Africa and Great
Right.
Britain and all of these places. So will the phase 1, 2, 3 trials that your group was conducting at Cincinnati Children's, will all of those have to be reperformed for each adjuvant or
Each variant?
new vaccine? Yeah.
And so that's a great question. We're hoping the answer is no. But so far, in vitro, it's been that the vaccine has still been very effective against the even the variant strains. If you look at the in the South African strain and the Janssen, that they didn't have hospitalizations, it looked like it worked pretty well even against the South African variant. With the AstraZeneca, the thing is there just wasn't that many cases, so it was hard to tell exactly how efficacious it was. But I think the decision was made there just because of the Janssen looked like it was a little bit better, that the country decided to go with the Janssen versus the AstraZeneca. But going back to what I was mentioning before, is that one of the very nice things about the mRNA technology and the adenoviral vector technology is that you can very quickly swap in and out a gene if need to, so that you can kind of tweak your your vaccine if need be. And then I wouldn't think you need to do the whole efficacy trial again, but at least some sort of comparison so that you can say what kind of immune response you're getting with the variant vaccine.
Great. We have a question from Shruti. So she's wondering, is there any evidence that the vaccines prevent individuals from carrying the virus? She was especially wondering if whether or not the vaccines can prevent transmission. Does that impact how quickly we can reach herd immunity?
Great points. So I thought she was going to say if we can get rid of these. And that so the that was why I was trying to show you some of the data from the animal models in the macaques as far as finding the virus in the nose. The data still are small, but there are some hints that the vaccine can prevent infection as well as disease. We know it prevents disease really, really well. So once you've had your vaccine series, whatever it is, the likelihood of you getting disease is pretty close to zero. Not at zero, but pretty close. the thing we don't know still is about infection. And so that's why, even though people have had the doses of vaccine, we're still asking people to have the masks on as they're going out in public, because we're worried of just that point, is that maybe somebody would be carrying the virus in their nose. They're not getting sick, but they're still able to transmit it to other people. And so those are some of the studies that are ongoing, is that we're actually getting swabs from people every 2 weeks that are in the study to see as if we can detect if they ever have virus in their nose or not.
Great. So Dr. Wazork had a question. He was wondering, do you have any more information on whether the virus can affect fetuses in pregnant women and how the vaccines work in pregnant women?
So they haven't been officially tested in pregnancy yet. There've been even though people have been told you're not supposed to get pregnant while in the clinical trial, there's been, I think, 34, 35 women that have gotten pregnant, and that there's been no anything that they've really seen of teratogenicity, but obviously it's very early, and that there's very small numbers. The American College of Obstetrics and Gynecology, or ACOG, has said that being pregnant is not a reason to avoid getting a COVID-19 vaccine. They really can't say anything more definitive than that until they're having clinical trials being done. That there's really no reason to suspect that the either the mRNA or the adenoviral vector vaccines would cause a problem to mom or the baby. But as scientists, we want to know for sure. The mRNA is degraded after about 2 days, so it is not long lasting in the system. And the adenoviral vector are replication incompetent, so they can't replicate in us. So again, there really shouldn't be a reason why it'll be a problem for women to get vaccinated during pregnancy. I could say is if you wanted to be the safest, to wait until past the 13 weeks of gestation, because after that, the babies basically are growing, that their organs are already formed, and for the rest of the pregnancy, the babies are growing.
Thank you. So Ethan said, "Hi, Dr. Frenck. Thank you for the presentation." He was wondering, what are the major differences between the Pfizer and the AstraZeneca studies, and what was the current status of the AstraZeneca study at Cincinnati Children's?
So the difference is that the Moderna and Pfizer are the mRNA vaccines, and then the AstraZeneca and Johnson & Johnson, or Janssen, whichever way you're going to call it, are the adenoviral vectored vaccines. So the AstraZeneca is using a chimpanzee adenovirus, whereas the Johnson & Johnson is using a human adenovirus. What they're all doing is making the spike protein, and they all look like they're making this pre-fusion spike protein. And so in the end, the immune response really looks pretty similar from all of the vaccines. So what I kind of look at the thing is that there are different mechanisms to try to bring the spike protein gene into our cell. But once it gets into our cell, what's being made is very similar, regardless of the vaccine. And so as far as the status, like I said, that we enrolled 503 people in the AstraZeneca study here, and they've all received their 2 doses of vaccine, and now they're in observation for if people get COVID-like symptoms, we ask them to call us, just like when Dr. Fichtenbaum was doing the study at UC with Moderna, is that if you get viral illness kind of symptoms, we ask to call so that we can do a COVID test on the person to see as if they have been infected or not.
Great. The final question was from Annie. She said, "Thank you so much for the very wonderful talk, Dr. Frenck. Do you believe that in the future we'll need to be vaccinated against COVID on an annual basis, similar to the flu vaccine?"
Can I tell you in a year? I don't know. And that if you look at SARS, and so this is called SARS-CoV-2 coronavirus, SARS coronavirus 2. If you look at SARS, SARS came from China, went into Toronto, caused havoc in Toronto, and then it just disappeared. And that's where there was some hope that COVID would do the same thing. It decided it didn't want to do that. But how much of a player it's going to be, how long it's going to be a problem, I don't know. Is it? It could be that what it does, it becomes an endemic cold in the population as much as anything else. And if you look at where a lot of the deaths are in people 65 and above, and as you're aging, the death rate is increasing. So it may be that if we're younger, even though we get infected, that we're able to tolerate the virus a little bit better. So it may be that we won't need repeat vaccinations. Part of it's going to depend on how much the virus mutates, because if our vaccine still works because the spike protein head hasn't really changed, then you won't need any more vaccine. But honestly, I think that's going to be one of the things I can tell you better in a year from now, unfortunately.
And then Ashley just had one more question. So
Huh?
she was wondering, have you seen any immunocompromised patients getting less severe side effects from the vaccine, or really any differences in the patients who are immunocompromised who are enrolled in the trials?
Well, so that would be the question. The other one would be, the question is, have you enrolled many people that are immunocompromised in the trial? And the answer there would be no. And that, so I can't really give you a good response there. Theoretically, what you could say is that because people are immunocompromised, they may not respond as well. But that's one of the things we want to check. And there's actually a plan, is that Dr. Laura Danziger and Dr. Grant Paulson, who are people here in infectious diseases that run the immunocompromised service for infectious diseases, are working on putting together a protocol to just look at that exactly, as far as it, is there any difference in immune response that people that have immunocompromising conditions versus those that don't.
Great. Well, I think that was the final question. So
All
thank
right.
you so much, Dr. Frenck. Really a fantastic presentation. We really appreciate you taking the time.
You're more than welcome. Have a great day.
Thanks, you too.